Hi everyone, happy Wednesday and welcome to Health Plus Weekly. I'm family nurse practitioner Hannah Raymond, filling in the hot seat tonight for Dr. John Podkowa, who will be back in next week. Before we get started with tonight's program, I'd like to just make a couple of announcements regarding some community events upcoming through Southcoast. First off is Camp Angel Wings is now accepting applications for this summer. This year's Camp Angel Wings will be on July 14th and 15th in Assonet, Mass. And the idea of the camp is that it's for children and teens aged 6 to 15 who are grieving the loss of a loved one. So activities at the camp include swimming, focused arts and crafts, discussion groups, and so much more. It's been a great hit historically. Space is limited. So to learn more about it, you can go to the southcoast.org website, and in the search bar you can search for Camp Angel Wings. Second on kind of the announcement list is the next Food for Tots is Thursday, May 17th, so in a couple of weeks. And that will be in Dartmouth. You can make a plan to eat out that night at selected Dartmouth restaurants. And when you do, 15% of your bill will be donated to the Pediatric Care Services at Southcoast Health. And so that's in collaboration with Boston Children's Hospital and the radio station Fun 107. And the radio station will be announcing the restaurants on Monday, so you can go to their website and find out all about that. So now on to the main event. Tonight we are talking about all things vascular. We're covering arteries, veins in your bodies, and some of the common problems that can occur, and also ways to keep them healthy. We are absolutely thrilled to welcome Dr. Richard Pinn, who's a vascular surgeon with Southcoast. So thank you so much for joining us tonight.
Thank you, Hannah, for having me.
And as always, you can write in your questions in the comment section of the Facebook Live feed. And I'm solo tonight, so I'll do my best to get to them. And if we miss them, I apologize in advance, but I'll do my best to get to everybody. So without further ado, welcome. And we just always like to start with kind of, how did you get here? Where did, how did you become interested in vascular surgery, and how did you end up in this area?
I've been in New England for about 5 years now. And originally grew up in Virginia, so...
I was going to say, I don't think that's a Southern New England accent.
A little bit of a transplant up here, yeah, not a Boston accent. And my family and I vacationed in Cape Cod about 4 or 5 years ago, and we just loved the area. And at that same time, there was a job posting for vascular surgery up here. We came up and interviewed. The people were fantastic, and so that's kind of how we wound up in New England. Okay. Vascular surgery has always been an interest of mine ever since medical school. I think we do a lot of things with a lot of different parts of the body, and I think it's one of those professions where when you do something, you can see a pretty immediate result.
Right. And we like that in medicine, certainly. How did you, through medical school, how did you kind of come to like surgery and then vascular surgery? How did your interest grow there?
I think I like a lot of the technical components of surgery, being able to focus on doing something with your hands, and again, being able to see a result pretty instantaneously in terms of getting blood flow down to a limb or fixing an aneurysm. So things that I think make a big impact, and you're able to do that in a way where you get a result immediately.
Immediately, great. So that's kind of a good segue. What is vascular surgery? It's kind of, you hear vascular, right. Is it a vein, is it artery, is it both? So could you kind of describe what it is?
I think it's one of those, it is one of those professions where not a lot of people know what is involved with vascular surgery. So I would describe it as working on blood vessels. So any blood vessel outside of the heart, whether it be an artery or a vein, if there is a blockage there or an aneurysm or any issue with that artery, that's when vascular surgery becomes involved.
Okay. And that's another kind of common question that we get in primary care. What's the difference between an artery and a vein?
So in general, arteries bring blood flow away from the heart, and veins bring blood back to the heart. And that's essentially the definition of an artery and a vein.
In a vein, okay. Yeah. But different pathologies can arise in an artery and a vein. So how how might somebody know that, so we know if we're having a heart attack or we're having a stroke, we know those common symptoms. How might somebody know if they have vascular disease, whether it's artery, whether it's the veins involved? What are some common, things that you see?
Sure. Sometimes, starting from the arterial side of it, when you look at a lot of the problems with the arteries, they may be asymptomatic. Mm-hmm. You may not even know you have an issue going on. For instance, strokes. So a lot of times blockages develop in the carotid arteries going to the brain. And you may not have any knowledge that that blockage has developed over time until you actually have a stroke. Right. And likewise with aneurysms in the belly or aneurysms in the chest, mm-hmm. you may not even have pain until that aneurysm actually ruptures. And so sometimes problems with the arteries are asymptomatic until they cause a real problem. Other times, there are warning signs. So, for instance, blockages that occur in the legs. Mm-hmm. A lot of people get what we call claudicating symptoms, meaning that you walk a certain distance, and after you walk that certain distance, you get pain in the legs. And it's reproducible every time, and it's something that can be very debilitating, particularly for folks who are very active. Right. And you're just unable to do those activities that you're able to do before. Going out with your kids, going shopping. Mm-hmm. So in terms of peripheral arterial disease, blockages in the arteries in the legs, many times you do have kind of a precursor, but sometimes it can be asymptomatic.
And that's a pretty good diagnostic, pain while you're walking, and it improves when you stop and then starts again, after a period of time.
Right.
And that pain is related to, is it just lack of blood flow and oxygen to the muscles? Is that correct?
Correct. Okay. Yeah. So at rest, when you're not doing anything, the muscles don't necessarily need that much blood flow or that much oxygen. But once you start actually pushing those muscles a little bit mm-hmm. and exercising them, and that demand for that nutrient supply and oxygen increases, and the body can't really get up to that level of meeting that need, then you start getting that pain.
Great. What about some common presentations of venous disorder, like venous disease?
There is really two different aspects of venous disease that we look at. One is the deep vein system, mm-hmm. which is the system that essentially drains those muscles and is the main system for drainage of the arms and legs back into the central part of the body and the heart.
So bringing the blood that's been used by the muscles and body tissue back up to get more oxygen in the heart. So
correct.
Bringing back, okay.
And that deep vein system is one that causes more of a life-threatening problem if there's an issue. For instance, if somebody has a problem with a blood clot mm-hmm. that forms in one of the veins in the legs, in the deep veins in the legs, something we call a DVT, mm-hmm. That blood clot could actually travel to the lungs and cause a major issue in terms of what we call pulmonary embolus. And that restriction of blood flow from the clot that goes to the lungs can cause a heart to go into failure and can be life-threatening. So the deep vein system is more of a life-threatening type right. Issue when something goes bad.
So signs to look for there, and we can talk more about this in a bit, but swelling, redness, pain, and kind of the risk factors that go along with that, kind of hard to ignore. Yeah.
Exactly what you said. So usually a very acute onset, mm-hmm. So something that happens where the patient knows exactly when it occurred mm-hmm. and suddenly develop pain, suddenly develop swelling in a leg, or suddenly develop chest pain and shortness of breath. And those are very common symptoms for either a deep vein thrombosis, the DVT, or a pulmonary embolus. And again, that is all a lot different than what happens with the superficial veins in the body. Okay. And when we start talking about the superficial veins, that gets more into some more chronic issues, okay. like varicose veins and perhaps chronic swelling of the legs when people are on their feet a lot mm-hmm. at work. Mm-hmm. And those are things that we also take care of. And those are things that usually are taken care of in a setting where you may not even need to go to the hospital.
Great. So those are some things to look for. Now, kind of backing up a little bit, can we talk about what we always love to talk about prevention on the show and kind of, what the public should know about how to prevent disease, because it's wonderful that we have such great resources in the community for when problems arise, but the main goal is to, avoid any illness, any injury in the first place. So what are some common causes of arterial disease? So kind of flipping
Sure.
back and forth between venous and arterial disease as a way to demarcate. What are some common causes of arterial disease?
So everything that we mentioned earlier in terms of blockages forming in the arteries, whether they're in the carotid arteries going to the brain or the arteries in the legs or even arteries that go to the intestines or kidneys, the main risk factor is smoking.
Okay.
And so it's usually related.
Add it to the list, right?
Add it to the list. So smoking is the main risk factor, and it usually is dependent on how long you've smoked and how much you've smoked. In addition, other things like aneurysms that develop in the body, which are essentially areas of the arteries that become weak and then become big and could rupture. The main risk factor for that is actually smoking as well.
Okay.
So that, I think, would be the, probably the biggest reason I'm in business from an arterial standpoint is from smoking.
Right, right.
And then other things that contribute are things like high blood pressure, high cholesterol, and diabetes.
Okay.
And so that in combination with smoking are probably the 4 biggest risk factors for either blockages in the arteries or aneurysms that occur in the arteries.
So again, I always, when I'm trying to describe it to people, we understand that those blockages can happen in your coronary arteries, and it's the same thing that's happening in all of the other arteries in your body, with the same kind of mechanisms causing it. So just those modifiable factors contribute. What about kind of things that people can't control? Do age, gender, family history have a role?
Sure. From a gender standpoint, men are more inclined to develop peripheral arterial disease regardless of any other risk factors. Certainly as we get older, the risk of developing blockages goes up, and also of aneurysms expanding in size.
Okay.
And so certainly older men with a smoking history, those are the ones that we become even more concerned about.
Gotcha. Good. And what about venous disorders? And those are the more common that we see, and that I'm sure you see. What are some kind of risk factors for developing? So the deep
Sure.
vein kind of things that we can talk about, but then some of the superficial things too.
So starting with the deep vein component of it, when people are more inclined to develop blood clots, it's usually from some sort of immobility, whether it is having, let's say, a knee or hip surgery, or being in a car accident and not being able to get around. Those are types of things that just because of that immobility in that limb, the veins don't drain as well.
Right.
And so with that stagnant blood flow, blood clots can form. Okay. Other things are particular medications that people take. Birth control pills are a very hypercoagulable medicine, meaning that they can cause the blood to become thicker and for blood clots to form more easily. Other things would be taking long plane flights or long car rides. In general, those are very safe things, but sometimes people have a predisposition from another factor, like a genetic factor, that makes their blood a little bit thicker, and so subtle things like a long plane flight could cause that to come out where you develop a blood clot.
Because when we think of blood clots, we think of provoked and unprovoked blood clots. So if you've just had surgery and you haven't been walking around and you get a DVT, we're a little less concerned about kind of the underlying. We know that that might have been the cause, and can draw a pretty good relationship there. But it's those kind of more subtle presentations of a DVT that we worry about in terms of underlying malignancy can increase the risk of a DVT, infection, and like you said, the kind of the familial kind of genetic clotting factors that we might want to look a little bit closer at as well.
Exactly. So yeah, if somebody has a reason that they developed a blood clot, that actually is more reassuring.
Reassuring, yeah. Not great, but
yeah, more
at least there's a reason. Right.
And when we start looking at the superficial system, when we start looking at folks who develop varicose veins over time or a lot of chronic leg swelling and pain. Many times that's related to occupation.
Okay.
So
we just had a question from John actually asking, what are some of the vein issues that can develop from being on your feet all day? So that must be one of the common occupations.
It happens to everybody, you know. Hairdressers, fishermen. I've treated fellow colleagues of mine who stand in the operating room a long time. So it's really any job where you're either sitting behind a desk for long periods of time or standing for long periods of time. And in those situations, gravity really plays a big role.
Okay.
And as you're standing or sitting, blood wants to go back down the leg. And over many years, because of that pressure of blood that kind of stagnates in the leg, there are valves in the veins that are supposed to keep blood flowing upwards towards the heart. Okay. And those valves start becoming compromised, and then blood will go in the other direction. And it's something that we call venous reflux, and or venous insufficiency. And some people describe it as leaky valves in the veins. And all of those things cause blood to back up in the legs, cause chronic swelling, particularly at work, and then a lot of achiness associated with that swelling. And visually, you'll see varicose veins develop. A lot of people will be concerned because they see a lot of skin changes that start to occur, particularly a lot of darkening of the skin around their ankles or calves. And that's because of this, excuse me, chronic swelling in the legs that causes blood pigment to get deposited in the skin, and that almost is like a tattoo. And
it doesn't enter back into the system when the swelling leaves.
Correct.
Yeah.
That's almost it's a rather
good diagnostic. Yeah, for that we kind of use also. Mike Hennessy just commented that he loves you and you're the best. So that's always nice to hear. Cheryl is actually wondering. She's noticed quite a few small spider veins over her inner ankles, which she's never had before. What could be some causes of and so that would be a superficial vein.
Right.
What would be some causes of like new spider veins?
So exactly how you categorized it. So this would be a superficial vein problem. Some people come into the office and they are very concerned about the spider veins because they hear a lot of things about vein problems and associate that with blood clots and a life-threatening issue. But many times if you see varicose veins or spider veins that you're concerned about, it's many times just a pain issue and swelling issue as opposed to something that is life or limb threatening. And that, I think, plays a lot into people's minds when they first come in and don't know that distinction. In terms of the spider veins, the main cause, again, is usually an occupation where you're standing on your feet for long periods of time. And it's just a back pressure of blood that develops into the vein and that causes these veins to get bigger. The spider veins are already there. They're within our skin. And
you just can't see them most of the time. Gotcha. Okay.
But as those veins get bigger because of back pressure, then you actually start seeing them. We usually treat those on a cosmetic basis where we stick a small needle into the vein and we inject a chemical that causes that vein to become irritated on the inside and that causes the vein to scar down and go away.
Great. Yeah. Is there any risk to eliminating too many superficial veins, or does it cause any kind of anything down the road that people should worry about, or can you just have an unlimited number of veins?
So that's a very common question, and particularly when you see large, ropey, varicose veins on the skin surface, and you're thinking, wow, these are probably really contributing a lot to the drainage of the leg. But that's usually not the case. These veins become big because of lack of blood flow directing upwards. They're not not working. Gotcha. And so these are actually accessory veins in the leg that the leg doesn't need. And in fact, at the point where you start seeing problems with the varicose veins, they're actually doing you a disservice because they're bringing blood in the opposite direction.
Gotcha. Okay. What about pregnancy and venous disease? Is it gravity again and just excess kind of body mass and volume that adds pressure to the system there?
Sort of.
Yeah.
So it's really extra mass in one particular area.
Okay.
So as the uterus enlarges, it actually flips backwards towards the spine a little bit. And the big blood vessel that comes up from the legs, called the vena cava, sits in that area. So the uterus actually pushes on the vena cava as pregnancy goes along. And so as that uterus gets bigger, there is less drainage of the veins of the legs, and so swelling typically will get worse during that period of time. And women may actually notice a lot of varicose veins that develop just during pregnancy, but then go away once they deliver. And that's actually not uncommon. Okay. So it is because of the enlarging uterus and where it sits in the pelvis.
Gotcha. So some degree of swelling when you're pregnant is normal, but pregnant women are also at higher risk for blood clots as well. It's in a certain period of time in pregnancy. So kind of those normal symmetrical swelling is okay, but any of those kind of alarming symptoms are something to watch out for.
I would totally agree.
Certainly. What about a history of? So I will sometimes see people who have gotten into a car accident and broken their leg 20 years ago, and they said my veins, my leg has never been the same. What role does trauma play in kind of the venous disorders as well?
So during trauma, particularly major trauma like a motor vehicle accident, there's going to be some sort of damage to the draining system of the leg, whether it's the veins or the lymphatic system. Okay. And many times after trauma, it can be a combination of the two. So disruption of the small veins in the lower part of the leg, or disruption of those lymphatic tubules that drain lymphatic fluid back into the veins, that can all lead to swelling and discomfort, as well as those venous stasis changes to the skin. Unfortunately, there aren't many things in terms of surgical intervention that we can do to improve that. Usually it's more conservative treatment in terms of compression stockings, and even something called a lymph press pump that folks can get at home that is covered by insurance, where you put your leg into basically a pumping device, and it squeezes that fluid back into the leg twice a day. Okay. Other times, trauma in the setting of, let's say, trauma 20 years ago, and the patient had a blood clot at the time of that trauma and had developed a lot of leg swelling in relation to that blood clot. Sometimes we can actually make that swelling a lot better now by getting back through that area of blood clot that might have been blocked off and putting a stent in and opening it up.
Okay, so great. That's good. So in terms of prevention for people who are on their feet all day, what do you recommend for preventing those varicose veins and those achy legs at the end of the day?
Right. It's tough to tell somebody to find a new job,
Right.
So
good luck.
Yeah. There are a couple of conservative things that can be done. One is compression stockings. So that's actually first-line treatment. It's a tight sock. And so it's a tight sock that we would ask the patient to put on while they're at work. And basically that tight sock just helps keep blood from going back down the leg and helps push blood up. And when that occurs, then many times people have less fatigue at the end of the day, less achiness in the leg, and certainly less swelling. The other option, the other thing is at the end of the day, once you do get home, try to keep the leg elevated. And so if you have a period of time during the day where the leg can recover and get that fluid back into the body, that actually does a tremendous amount in terms of making the leg feel better overall. Ultimately, if there is a component of reflux, and we would diagnose that usually with an ultrasound. So
they would come to you, you would maybe do the ultrasound, see if there was any reflux, or maybe recommend the conservative therapy with the compression stockings first, and if that didn't work, see if there was reflux.
We usually do both simultaneously. So we'll go ahead and start the compression stocking wear, and then at the same time we'll get an ultrasound and look for reflux. And at that point, it really depends on how the patient's symptoms do with the compression stockings. So if the swelling and the pain in the leg goes away just with compression stocking wear, we may not need to do anything else. If it doesn't go away or the symptoms start getting worse, then the next step would be to get rid of that malfunctioning vein that we see on the ultrasound.
Great. So that kind of lends us to another thing that we always like to talk about. How can people get in touch with you? Where do you practice? How, what's your practice like? What does it set up like?
Sure. We have offices located in North Dartmouth, right off of Fons Corner Road, exit 12. And then we also have offices in Middletown, Rhode Island.
Okay.
The office setup is kind of sort of a dual office.
Mm-hmm.
One side of it is general vascular surgery. And then the other side of it is what we call a vein clinic. And that is more of a spa-like environment where folks come in to get varicose veins and spider veins treated. And those types of treatments occur right in our office. Usually the treatment takes less than half an hour, and it's typically a very benign procedure that we can do very comfortably in the office.
Okay. So what are some of the procedures? I know you spoke about kind of injecting the chemical into the spider veins. What are some of the other things that you do in the office?
Sure. So the ultrasound that we get is the determinant as to what sort of treatment we can offer. And right now what we do for reflux in the veins in the legs is a procedure called radiofrequency ablation, where we access that malfunctioning vein with a needle and put up a straw into that vein that vibrates quickly and basically generates heat. And when that occurs, it causes that vein to shut down. And when the vein shuts down, now you no longer have that back pressure of blood going down the leg. And so that takes the pressure off the leg, it gets rid of the swelling, gets rid of the varicose veins, and gets rid of the discomfort. The vein, again, is an accessory vein that the leg doesn't need, and so the main veins, that deep vein system, still does its normal job of carrying the blood up the leg. So again, that's radiofrequency ablation. That's something we do in the office. We are going to be doing, probably within the next 3 to 6 months, another procedure in the office where instead of heating the vein up, we actually inject a glue into the vein to seal it up. And even though the heating procedure, the radiofrequency ablation, is not painful per se, you do have to give some numbing medicine along the thigh usually to numb up the vein before you do it. Whereas with the glue procedure, you don't need to do that. And I think that's probably a procedure we'll start doing within the next 3 to 6 months. It recently got approved.
Great.
The spider vein procedure is a very benign procedure where we essentially put a needle into the spider vein and inject a chemical. We use a chemical called polydocanol, and it causes an inflammatory response inside the vein, and that essentially causes that vein to collapse and scar down and go away.
Great. Who are the other physicians, surgeons in your office?
The partners that I have are Dr. David Gillespie, who's actually the chief of our division, as well as Dr. Michael Iad. Great.
And any nurse practitioners or PAs with you?
We do. We have Diane Rio. She's our nurse practitioner in the office. And then we also have a slew of nurse practitioners and PAs in the hospital that help us out as well.
Great.
Yeah.
So the vein center or vein clinic on Fons Corner Road, and referral through your primary care physician, or I'm sure searching on the website and calling the office too is a good way to get in touch with you.
Absolutely.
So kind of, are there a lot of new procedures kind of in the works for vascular surgery, or what's the kind of development in the field?
Sure. I think one of the exciting things that we've been doing recently deals with blockages in the carotid arteries. And it's a procedure where we are able to put a stent in the carotid artery with a very minimal stroke risk. So the whole reason that we treat blockages in these carotid arteries going to the brain is to prevent stroke. But anytime you work on that artery, there's also a risk of causing a stroke. And at this point, the gold standard for fixing those carotid arteries has been a major surgery, where you make a big incision in the neck and you actually physically open up that artery and clean out all of that plaque, and then sew the artery back up and sew the neck back up. We are doing something a little bit different now, where we make just a very small incision, about a 2-centimeter incision at the base of the neck, and then a separate puncture site in the groin, and we are able to put a stent up into that carotid artery, and we do it while we reverse blood flow in the brain. So blood actually, instead of going up to the brain, goes in the opposite direction, comes out of the body and goes through a filter and then goes back into the body.
Okay.
So any
So
particular...
bypasses the heart or the normal
Correct.
system, yeah, but it's still getting oxygen to the brain.
Exactly.
Okay.
And that procedure essentially prevents any particulate matter from going to the brain while we put the stent up.
Oh, great.
And so that has a much lower risk of stroke than the other ways to fix
Than the
carotid artery.
roto-rooter that you
Exactly.
used before.
Exactly. And it's a procedure that isn't done all over the place.
Okay.
So this is a procedure that recently got approved in end of 2016.
Mm-hmm.
And it's only sort of select institutions around the country that are able to do it. And we just happen to be one of them.
Great,
So.
great. So sticking with kind of carotid artery disease, so flipping from the venous system in the lower legs to back to the arterial system kind of in the neck, we do worry about, that's one of the main things that we kind of worry about, because you can develop disease, like you mentioned at the very beginning of the show, without even knowing that it's there kind of until it's too late. So carotid artery stenosis is that, thickening of the artery, plaque buildup within the carotid arteries that bring the major blood vessels to the brain. What would be some, symptoms that people might have?
So, interestingly, things like headache or neck pain are not usually associated with blockages in the neck. But sometimes these blockages can cause a precursor before a major stroke. And one of the things would be suddenly losing vision in your eye. And this may be a very transient thing. It may only last a few seconds. But if you completely go blind in one eye, then it could be a little piece of plaque or a little piece of a blood clot that actually has gone into the artery that supplies the retina of your eye. And so that's something, the fancy medical term called amaurosis fugax. And it is something that is very, something that we ask about when we start talking about carotid artery stenosis. Right. Other things would be what we call a TIA. It's also known as a transient ischemic attack, and some people may call it a mini stroke. And that is something where, let's say you aren't able to speak or move your arm or move your leg, but it only lasts for a few minutes or even an hour, and then those functions come back. And it's kind of a warning sign that, right. Okay, now, there is a blockage in that carotid artery where it's causing trouble, but luckily it hasn't caused a major problem yet. Right. So that's also a warning sign.
A warning sign. And sometimes we can actually hear it when we listen to the carotid arteries. There's a increase in kind of the sound that the blood makes over the blockage there too.
And so usually that's how folks get sent to us if they haven't had any symptoms, is a thorough primary care provider has taken the time to listen to the arteries in the neck and hears that whooshing sound, something we call a carotid bruit, which
it's dramatic. Yeah,
it is dramatic.
When you hear it, yeah.
And it's turbulence in the artery, and that turbulence, it's so pronounced that you can hear it with a stethoscope, and sometimes you can actually feel it with your hand. Right. And that's certainly something that would prompt us to do a further workup.
And what would be the next thing that somebody would have done for a workup? Yeah,
usually an ultrasound. And totally non-invasive test. We put some jelly in the neck and a probe on the neck, and from that we can basically take an ultrasound picture of the carotid artery.
And that shows you the percentage of the artery that's blocked. And so kind of where do people go? There's medical management for the narrowing of the artery, but then there's that surgical treatment that you spoke about. Where does the line cross there for people?
It's a little bit fuzzy. A couple of decades ago, they did a major trial looking at medical management versus doing some sort of intervention for these carotid arteries. And in general, they found that if you had a symptomatic blockage, meaning that you've had a TIA or you've had some blindness in the eye, if you had some sort of symptoms, that if you had greater than 50% blockage, you may benefit from having that artery cleaned out. And if you did not have any symptoms, but let's say you just heard that turbulence in the artery and you got an ultrasound and you noted that there was more than 70% blockage, you may be a candidate for getting that artery cleaned out surgically. But again, that was many, many years ago. And now we have medicines that are around which can help prevent clots from forming on those blockages that go to the brain, and one of them being Plavix. So it's a little bit of a fuzzy area now because we really don't know how the addition of those newer agents like Plavix can change the risk.
Study, right?
Yeah, so at this point, I would say most folks would agree that if you had an asymptomatic blockage that was greater than 80%, you would probably benefit from having that cleaned out.
Okay.
Likewise, if you had a symptomatic blockage that was greater than 70%, you would probably benefit from having things cleaned out.
And otherwise, we're just worried about, controlling your blood pressure, controlling your cholesterol levels and, the lipid profile, and then being on an antiplatelet or, something that thins the blood, and like an aspirin or a Plavix as well. So that would kind of be the treatment leading up to, prior to surgery.
Correct. Exactly what you mentioned. Some sort of antiplatelet agent, aspirin or Plavix, and good cholesterol control. So many times Zocor or Lipitor or something along
and
those
no
lines.
smoking, of course.
And no smoking. Yeah.
So what are the arteries in the neck can produce kind of the transient stroke-like symptoms sometimes. What about the arteries in the lower extremities? We talked about the claudication symptoms. What's the diagnosis? So if you come to you, you have pain with walking, it stops, at rest. What would be the next step in terms of diagnosing, peripheral arterial disease?
Yeah, for chronic peripheral arterial disease, folks will have this claudicating symptom. And again, that is reproducible pain, usually in the calves or the thighs with walking a certain distance. So every time you walk 100 yards, you get that pain. And if you take it easy and don't do much walking, then you don't have pain. The physical exam actually becomes very important.
Okay.
If you are able to palpate pulses in the feet, meaning you can feel them with your hands, it's unlikely that you're going to have a degree of peripheral arterial disease which would lead to those types of symptoms, and you may want to start looking for something else.
Okay.
If you don't have pulses that we can feel, then the next step is what we call a PVR, or also known as a pulse volume recording, which is essentially a fancy word for just taking blood pressure measurements of the legs. And we compare that blood pressure cuff measurement in the leg against the blood pressure cuff measurement in the arm, and depending on that ratio, we'll know how much blockage there is in the leg.
So we talk a lot about the blood pressure system, the arterial system as a closed system. So the pressure should be the same or relatively the same in all areas at the same time if there's, unless there's a blockage someplace.
Right.
Okay.
Yeah.
So then if you do diagnose a blockage in the lower arteries, what would be the next step there? Is it the same kind of criteria or similar criteria, or is it based more on symptoms?
It really depends on the symptoms and the functional activity.
Okay.
So, for instance, if the symptoms are rather severe, but the patient hasn't really tried to walk much past the pain, then we can prescribe what's called just an exercise program, essentially, where we try to increase the patient's walking tolerance by walking through the pain a little bit and increasing that duration over time.
Okay.
And some people will get a good benefit out of that, where their pain level decreases and they don't need anything else done because they're able to kind of lead a very comfortable life at that point.
And do what they want to do. Gotcha.
Exactly.
Okay.
And there's another medicine called Pletol that we can put people on that will also improve that walking distance. If those two things don't work, then the next step is a catheterization of the leg, where the patient comes to the hospital. And
so not done on Fons Corner Road.
Not done in Fons Corner Road. So it is an invasive procedure, but it doesn't require any incisions. It is a needle stick, typically in the artery in the groin, and we shoot pictures of the blood vessels that go down the leg. And anywhere that we see a blockage, we try to open up with a balloon or a stent. And for folks who come in with claudicating symptoms, probably about 90% of the time, just with the catheterization, we're able to open up those blockages and get good blood flow down to the foot where they don't need anything else done.
Wow, great.
About 10% of the time, those blockages are too severe, they're too calcified, and even with things that, like a laser that we can use in the artery, it can't get through those blockages. And in those settings, then, we do have to revert to surgery, where we do a bypass around that blockage.
Okay, so again, just as you would have a catheterization or a bypass in your heart, it's the same idea in the lower extremities.
Exactly.
Okay. What role does vascular surgery play in like non-healing wounds, or development of wounds? Are there different characteristics depending on the different type of insufficiency?
Short answer is yes.
Okay.
So with wounds,
that was a lot. Sorry, that was a lot in one question.
with wounds, the first step is to determine if it is an arterial problem or a venous problem, and again, that goes back to physical exams. So we're able to palpate pulses in the feet, and a patient has a wound on their leg or their ankle or foot. It's unlikely that it's an arterial problem that's causing that. And so at that point, we would start looking at the veins, and then the next diagnostic step would be that ultrasound of the legs to look to see how those veins are functioning. If the pulses are not palpable, then again, the next step would be that PVR test to look to see how much blood flow is getting down through those arteries to the leg. And based on your physical exam and those tests, then we can decide exactly what we want to do. But the ulcer is essentially a sign of a severe arterial problem or a severe venous problem, something that needs to be dealt with.
And do you find that after you do treat the underlying problem that those areas heal quicker and that it's more dramatic?
Absolutely, absolutely. So anytime you have a blockage in the arteries and you're not allowed to get enough nutrients down to the foot, once you sort of reopen the supermarket and all those nutrients get down there, then the wounds heal up very quickly.
I like that analogy, the supermarket. Good. Let's see. What about, let's kind of transition to talking about aneurysms. So you mentioned it a little bit at the beginning of the show about, it's a thinning of the walls of the artery. Could you talk a little bit about what an aneurysm is and who chose to name it that? And it's so hard to spell every single day. I'm struggling with, typing aneurysm, but.
I think it may be a Latin for dilatation.
Oh, so they're long gone. We can't blame them.
Right. The aneurysms, the main risk that we worry about is rupture. Okay. Sometimes we also worry about turbulent blood flow in those aneurysms becoming so stagnant that it can cause clot to form in them, and those clots can either shut down the artery or what we say embolize, meaning a piece of that clot breaks off and goes to another part of the body. So those are the main concerns of the aneurysm, and the main risk is rupture. And the larger the size of an aneurysm, the more risk there is of rupture. The risk factors that we talked about before in terms of being male, being a cigarette smoker, high cholesterol, diabetes, those types of things all contribute and all play a role in not only the formation of these aneurysms, but also these aneurysms getting bigger. They looked at these risk factors probably a decade or two ago, and they noted that, okay, men who have smoked a certain amount of cigarettes over the course of their lives, or women with a family history and who have also smoked a certain amount of cigarettes over the course of their lives actually have a much higher risk of developing an aneurysm. And so Congress passed something called the SAVE Act, which is essentially SAAAVE, with the 3 A's in the middle being abdominal aortic aneurysm.
Is that the most common site of an aneurysm?
For the aorta, it is.
Okay.
And with that SAVE Act, anybody who qualifies for Medicare, who fits certain criteria, can get a free ultrasound as a screening tool to look for these aneurysms.
So those people would be males over the age of 65 with a smoking history, or males over the age of 65 with a family history, or women over the age of 65 with a family history? Or is it a little bit, who else should be?
Yeah, and also the smoking history.
With a smoking history. Okay.
Yes, exactly.
Okay.
And
so if anyone fits into that category and hasn't had an ultrasound, that would be something you could approach your primary care provider about. We do that pretty frequently, just a one-time screen. If it's normal, then we don't tend to repeat it unless there's other risk there. But so if we were to find a little dilation on that ultrasound, we would send them to see you. And what would be the next step there?
Right, and at that point it kind of depends on the size and where the aneurysm is located. For aneurysms of the aorta, particularly in the belly, we typically use a cutoff size of around 5 centimeters.
Okay.
Typically below 5 centimeters in size, the risk of the aneurysm rupturing is exceedingly low. Once you hit that 5 centimeter mark, that's when the risk just starts to go up.
Okay.
And so at that point, that's when we start thinking about whether or not we should fix it. And it depends a little bit about location of the aneurysm and the other comorbidities in terms of whether or not we have any heart disease or kidney disease or lung disease that may increase the risk of surgery to fix the aneurysm. These days, aneurysms, for the vast majority of them, can be fixed through a minimally invasive approach.
Okay, so not a big opening of the chest.
Correct.
Okay.
Yeah, and that used to be how all aneurysms were fixed. Either a big chest incision or a big belly incision, and you would go in, open up the aneurysm, sew in a new tube to it, and reestablish normal blood flow through that tube and get rid of the aneurysm physically. These days, the more common approach is just a small incision in both groins, usually about 2 centimeter incision in the groin, and we put up a new lining to that aorta, what we call a stent graft. And that stent graft seals up the aneurysm, prevents any blood flow from getting in there, and at the same time maintains blood flow getting down to the legs, into the kidneys, into the intestines. And because it only needs a small incision in both groins, the recovery is much quicker. Yeah. So with an open aneurysm repair, we're talking usually about a week in the hospital. Okay. And the first several days of that being in the intensive care unit, and probably realistically about 3 months before the patient really feels like themselves again. With the minimally invasive approach, what we call endovascular aneurysm repair, usually folks stay in the hospital overnight, go home the next day, and probably within a week are feeling like themselves.
Back to normal. Great, yeah. Great. And short of surgery, do you monitor, how frequently do you monitor the aneurysms that don't hit that criteria, hit the cutoff?
It depends a little bit about the size of the aneurysm and the rate of growth. So aneurysms kind of approaching that 5 centimeter mark, particularly if they have grown recently, we may be in a position where we get an ultrasound every 6 months. For aneurysms that are smaller, let's say in the 3 to 4 centimeter range, we may just get an ultrasound every year. And that's how we keep an eye on it.
What about aneurysms in the brain? So no real guidelines for screening on that.
Right.
How do we usually find those? How do we usually discover those?
Those brain aneurysms do not have the same risk factors as the aneurysms that we treat from those issues with smoking, high blood pressure, high cholesterol. Right. Those risk factors are a little bit different for the brain aneurysms. Sometimes, in fact, I think most of the time, those brain aneurysms are asymptomatic. They may not show any type of sign whatsoever, and a patient may get a CT scan for another reason, and see that they have an aneurysm. And at that point, once you're into the arteries into the brain, that usually goes on to a different specialist, either a neurosurgeon or a neurointerventional radiologist.
Yeah. What about family history of an aneurysm? Should people be kind of aware if they have maybe like a sister or a father or a child that has had an aneurysm in their head and get checked out?
Family history does play a role.
Okay.
Some aneurysms do run in families. There are certain genetic conditions as well that predispose to aneurysms. Okay. Things like what we call Marfan syndrome or Ehlers-Danlos. And those are symptoms, or those are syndromes where the connective tissue Basically, the fibrous part of that blood vessel that holds the blood vessel together is weak genetically, and that just allows for that blood vessel to get bigger under much less stress. And so there are genetic issues that could cause that, and then family history alone.
Right.
Outside of that.
Right. Great. So we're all caught up on questions here. Was there anything else, is there any public service announcement that you'd like to make, something that you wish everyone would know about kind of your specialty and kind of the health of your veins and taking care of that part of your body that we don't really, like you said before, we're not really, it doesn't get a lot of attention and people aren't really quite sure what, vascular surgery is?
I would say if it is something that you can see, like a varicose vein that you're concerned about, come in and get it checked out. It's not something that there's any pressure about to have any procedures done, but if you're concerned about something, come into the office. We can certainly evaluate it well with a physical exam and then a very benign ultrasound, and that can kind of give you the answers that you may have been worried about for a long time.
At least put your mind at ease.
Exactly.
Yeah. Because they can be unsightly and painful, and maybe the pain and the symptoms that you're having are kind of outweighing the kind of severity of the issue. So.
And then the other thing I would say is that if you are a current smoker out there, just know that a lot of the problems that vascular surgeons deal with are related to smoking, and cutting back on cigarette smoking or quitting cigarette smoking is a huge deal when it comes to prevention. Prevention.
We had a couple last minute questions come in. One from Jeanette asking if there are any supplements, so over-the-counter vitamins, minerals, any remedies that can help with blood flow that you're aware of.
Not that I'm aware of.
That you're aware of, yeah. And Joanne, again, says she loves you and you're a great doctor and you're very knowledgeable. So I think that's really come across tonight, and we appreciate you taking the time to come here and kind of everything that you do for the community as well. Take home messages like you said, the same thing. No smoking. Let's control blood pressure, high cholesterol, physical activity, diet. It all plays a role in not just your vascular health, but your whole health that we've coming to find out more and more each week here. So just before we part, I want to just talk again about the Camp Angel Wings on the southcoast.org website. If you want to search for Camp Angel Wings, that will be held on July 14th and 15th this summer. Again, it's a camp for children and teens age 6 through 15 who are grieving the loss of a loved one. Lots of activities there, and just a fabulous program. And the next Food for Tots is Thursday, May 17th in Dartmouth. You can check on the Fun 107 radio website for participating locations there, with proceeds up to 15% of your bill going to the pediatric services at Southcoast here. Again, I'd like to thank everyone for tuning in and for your continued support and interest in the show. Thank you, Josh, our wonderful producer, for all the great work you do kind of behind the scenes. Dr. Penn, we can't thank you enough for coming, and we hope you come back, and everyone's summer legs will be thanking you coming up. And be sure to tune in next week's Wednesday, 7 p.m. We'll be talking with a couple of our resident pharmacists about some common diabetic medications. Until then, stay healthy, Southcoast.
I started dancing at age 3, and I kept on dancing. I never stopped doing things. I liked to travel. I was walking in Iceland, and it was very painful. Not only are you in pain, but it's the fact that, oh, I don't think I better do this. I could create something that's worse than I have right now. And I really thought, I hope someone will listen to me. And that, I think, is the most important thing. And I was asked, what would you like to be able to do? And I said, I want to be able to do everything. I want to be me. I want to be able to walk. I want to be able to climb. I want to be able to dance. And I want to be able to feel secure. Southcoast listened to me. I felt that it was my decision. I was in control of the situation. I felt a lot better about it. After the procedure, you feel liberated. You feel like you are your own person again. It's a wonderful, wonderful feeling. I've had good care. I've had people to answer all my questions. I feel secure. I've had surgery up in Boston at one point in my life. The care that I received here was far superior, and I just felt like I was home. I'm walking with a brand new hip, and it's doing very well, and I feel good. I'm back to where I want to be. There doesn't feel like I have anything that I can't do. When I was at the Jazz Fest and I heard the music and I started and I thought, you know what? I'm dancing again.
I became a fisherman. I used to scuba dive for quahogs, and that was heavy work. When you're self-employed, you gotta keep going. I kept hurting my back. Then I found out I have degenerative disc disease. I deteriorated to the point that I couldn't stand up. The pain was just so severe. It affected me emotionally, psychologically, and physically. I had probably 12 surgeries, and I wanted to give up. The pain was just so bad. When there's no relief in sight, what else do you have? My general physician, I went to him, I told him I wanted to go to Boston, and he said to me, before you go to Boston, I know a guy at Southcoast Health. So we met with the neurosurgeon at Southcoast Health, and he told me what he was going to do. That's when I started to get happy. The pain had subsided. I wake up happy. I go to bed happy. I can stand up. I saw my surgeon 6 weeks ago. He says, Bruce, you're doing well. And I said to him, you saved my life. And without you, I don't know what I would have done or where I would be today. Yeah, there's a lot of tears, even on his part. I can't tell you how much of a difference it's made in my life. It's totally different. Now, bring it on. Life is good.